So we're going to go through common cases that you can see in the A&E department. What we're going to do together is we're basically going to clerk a patient together, and then I'm going to leave you on your own to do the next two cases. Now, this is an interactive session, so I want you all to unmute or use the chat box to tell me what you think we might do. And these are very common cases that you see in A&E department. And we're going to start with the very first one. And case one is basically a 91-year-old who's unable to weight bear after falling from her bed this morning. Okay? So everyone's got that.
Neck of femur fracture.
Yeah, neck of femur fracture. Now, this is one of the most common cases that you can see in A&E. And
Fragility fracture.
yeah, that's right. So this is one of the most common cases, and you're actually expected to do most of the stuff on your own. Now I'm just gonna open a like Word document right now, and we're gonna clerk this patient together. So I'm just gonna show you how the notes look like and what exactly is expected to be written in the clerking of any patients. Now, clerking in patients in the NHS is mainly the same way. The only difference, as I said, that in A&E, you don't really do anything further apart from just clerking the patient and then taking the decision to send them home or to admit them. So you don't do ward rounds. So can you all see this Word document right here?
Yes.
Yeah, perfect. Okay, so we have a 91-year-old patient who's coming after a fall. So basically, in any single clerking in the NHS, you have to specify who you are. Now, when it's a computer system, it's automatically put on, but sometimes you're going to see that you write your name and your grade before starting. So before starting, you just write, what are you doing? So this is ED clerking, GPST1. Okay, sometimes you write your name. So let's say, and you do by writing your surname, which is, and then GPST1. Okay, and then you have to write the present complaint. So these are abbreviations that you're going to use all throughout clerking or even ward rounds in the NHS. And PC stands for presenting complaint. And this patient is coming with a fall. Okay. Now you're going to take a history from this patient. So history of presenting complaint. Now, when you're clerking patients in the NHS, you can't actually take the laptop with you or the computer with you while you're talking to the patient and just typing while you're talking, if that's easier for you. Some other doctors do it by just memorizing what the patient says and then they write it later on. So whatever way you want to do it, just feel comfortable to do whatever is easier for you. Now, we saw this patient, and this patient tells us that she just fell out of bed. She hit her leg. And then what else do we need to ask in an elderly fall patient? There's a few questions that we need to ask, especially after a fall, to make sure what exactly do we need to rule out.
If she uses blood thinners.
Yeah, if she uses blood thinners, why is
Head injury.
Yeah, this is important because if there's a head injury and they're using blood thinners, then it takes us to a totally different case. Okay, so we need to know if they hit their head, if there was any loss of consciousness, if there was any other injuries. And you always ask, with any fall, elderly or not, if this patient was able to weight bear after the fall. So was this patient actually able to just get up and walk around? Because if this patient has been able to get up and walk around, then it's most likely not a fracture. So we'll say patient fell this morning out of bed, hit her right side, for example, no head injuries, no loss of consciousness, no nausea or vomiting, let's say no headaches, unable to weight bear after fall, have to call ambulance, for example. So we need to know how, why, and how did she come into the A&E, because this is someone who's unable to weight bear. They came in a certain way, and it just gives us insight if the patient has been with anyone. For example, she shouted out for help and there were people around at the house, or she used what we call lifeline. So it's very common to see that with elderly patient, they'll have like a bell on them and they just press it and ring it, and then it basically sends help. So you'll just ask them how exactly they came here. So for her, for example, let's say she used the phone and she called the ambulance. And the ambulance came in. Now you usually ask what the ambulance gave, because sometimes the ambulance might have given strong painkillers or they've not given anything. So got paracetamol. Right.
Is there any safeguarding issues we need to be concerned about?
Yeah, in elderly and children, any falls we usually ask, but it falls under the social history. So if they're living alone, we don't really bother because it's usually not going to be a safeguarding issue. They just fell.
Right.
Now the other thing to keep an eye on when there's a fall in elderly, we just need to know like what happened. What is the mechanism of fall? Was she just rolling in her bed and she fell, or was it actually that she got very dizzy while standing up, that she fell to the ground? Because then we'll need to do an ECG. We'll need to look into the reason why this patient, for example, almost fainted or was dizzy. So again, in a fall in elderly is a very, very common presentation in A&E. Maybe almost 40% of the patients you're going to see are fall in elderly. And you need to rule out so you basically need to rule out any causes in the brain. So any bleed, any stroke, any chest causes, which is MI, any vertigo. For example, they had vertigo and they fell, and that's why they sustained this injury. And again, as you've mentioned, any safeguarding concerns. Okay, so this patient was pushed. The mechanism of falling or the story doesn't really line up. For example, the patient says, "Oh, I fell out of bed," and then when you speak to them a little bit more, they're like, "Oh, I fell in the garden," with no history of dementia whatsoever. So this, query safeguarding concerns. Now, we're happy that this patient was rolling out of bed and just fell, hit her right side. You need to write the mechanism of fall. So let's say fell this morning out of bed. Let's say rolling out of bed. She hit her right side. She was unable to weight bear, and basically that's the history. There's nothing more to ask about in the history presenting complaint. Sometimes you might ask if this is something that's recurring. So if this patient has always been falling, so this is a high risk of fall, especially when they're like standing up, when they're, for example, walking around, and this is their 12th or sixth fall in a month. Now, this goes under fall clinics. So someone was asking about clinics. There's something called the fall clinic. Okay. And patients with high risk of falling, we refer them to fall clinic if we're going to discharge them home. So let's say we're happy with our history. We've asked as much history as we can for this patient. We're happy that there was no issues, no neurological deficit, for example, just to rule out any strokes, no facial dropping, no weakness. So this patient just fell, basically. The other thing that we write on, and it doesn't necessarily have to be from the patient, when you're looking at the patient's notes, you're going to see their past medical history, but you can just review it with the patient. So let's say this patient is known to have heart failure, known to have COPD, dementia, for example. You just write the past medical history as it shows in the patient's note, and then you can go through with the patient. Of course, if someone has heart failure, COPD, dementia, they're still going to have these problems. It's not going to be something that just goes away. But if you see, for example, UTI as one of the diagnoses that's been recently done by the GP, you can ask them if they still have the symptoms of UTI or not. Okay, and then you write the medications. And that also gives an idea.
So,
Sorry, go ahead.
yeah, thank you so much. So this past medical history,
Yeah.
will this be filled in the system, or do we need to ask the patient directly by ourselves?
No, so the past medical history is usually you find it in the notes in something called LPERS, which is the patient's GP notes. Okay, so I'll write it in the chat so you all would know. It's called LPERS. It's the GP notes. It's not filled in automatically. In pediatrics, however, whoever is starting pediatrics, in this computer system, the past medical history for peds is filled in automatically.
Got it. Thank you.
But we still write it in the clerking either ways, okay? So when you clerk the patient, you need to write all this history, even if it's in the notes somewhere. Um, Okay, so then we ask about medications. Now, medication is something that you need to review with the patient. Again, you're going to find it in LPRIS, which is the GP notes. But sometimes they've stopped certain medications for a certain reason, or they're not taking their medications regularly. And then let's say this patient is on ramipril, lansoprazole, amlodipine. Okay, and sometimes if you don't know why this patient is taking something, so let's say this patient is taking cocodamol. There's nothing in the past medical history that would justify why they're taking cocodamol. Just ask, okay? Ask them why they're taking a certain medication, if it doesn't make sense to you. And they'll tell you, oh, because, for example, this happened and that happened, and you can write it then if you want to explain it a bit more in your notes, or just add the past medical history if they've given you something, a new diagnosis that they just had. Now, after this past medical history and medications, we usually comes the social history. And can anyone tell me what do we ask in the social history?
Where does they live? Where does he live, or where who with whom they live,
Yeah,
and also like about the housing a little bit.
yeah, that's right.
How do they mobilize?
And next of kin.
Next of kin, true. A lot of people are writing smoking and alcohol. Yeah, yeah, that's right. So basically, in the past medical history, we're going to ask first about mobility. Okay. And usually there's something called ADLS, other dependent. And this means activity of daily living. Okay, so in elderly especially, we have to write dependent or independent of ADLS. And this tells us of the mobility of this patient. So if this patient has been doing everything on her own at the age of 90 or 91, I would say this is a very fit patient. If the patient is independent, so we just write independent, and then we write what kind of help she's getting. So carers 4 times a day. And in elderly, especially, it's very important for us to write how they're walking, their mobility. So using a frame, for example. Okay, using a stick, using a wheelchair, whatever way, a bed bound. So you have to write their mobility, especially in elderly. So we're going to write dependent or independent with daily activities. We're going to write the amount of care they're taking. If they're not having carers, but the family are coming in, then we're going to write, for example, son or daughter visiting daily, using a frame. And then, of course, smoking and alcohol. No alcohol. And also it's important in falls because it gives us an idea, is it secondary to alcohol, which you'll find it quite common in elderly patients. Sometimes when they're on their own, there's nothing better for them to do. They might drink like a bottle of wine a day. So that might be contributing to their falls. Okay, so it's important to ask, or do they drink alcohol? Sometimes in some patients, they'll tell you, not really, or like, yeah, socially, please quantify. Ask them, what do you mean by that? Because some people would tell you not really, and then they end up drinking a whole bottle a day. And for them, this is a normal amount. Okay, so we've asked about the social history. Also, when there's a fall or any kind of fracture, it's good for us to ask the type of house they're in. For example, they're in a bungalow, they're in like an apartment. What are they in exactly? Okay. Because then it would let us know when we're discharging this patient, is there anything that we need to do in the house itself, or is it okay? So if they have, for example, stairs inside the house and we're discharging this patient, do we need to send someone in to put like an electric chair in or to put rails on? So it's important to know the type of the house they're in. Now, when we finished all the history that we took from the patient and from their notes, now it comes our turn to writing what we've done so far. So we write the investigations next, and then we write exactly what we've done. Usually with falls, we do an ECG, which most of the time comes back as normal. In some cases, we might pick up an AFib, okay? And that might also be the reason why they fell. Sorry, whoever just spoke now.
What about X-rays?
Yeah, in investigations, we're gonna write X-rays. Okay, so we're either it's been done or not. A lot of time it's already been done in the triage, but if it's not, then just don't write it, leave it blank because it's gonna be in your plan. Bloods are usually done. And if there's nothing in the blood, you just write nil acute or NAD. Okay, so nothing significant or nothing acutely. And some patients might have, for example, let's say they have a certain kidney function, say KD3, but it's nothing acute. So it's not really contributing to what we're seeing now. So you don't really write it in because it's nothing acutely that's been happening. If we've done a CT, we write it. If we've done an X-ray, we write it. We write whatever investigation has been done. When we write the investigations, we usually follow it by the news score. Does everyone remember what the news score was? What was it for?
National early warning sign.
Early warning signs. Yeah, that's right. So basically early warning signs, and then we write exactly what is the early warning signs. Yeah, it's vitals, monitoring. Sorry, NAD is no abnormality detected. That's right, Augustine. So basically, if the news score, we're gonna write whatever number it is, 0 to whatever. Let's say this patient is scoring a 0. Okay. Usually people with like fractures or like query fractures, the news score might not be 0 because they're in pain, and pain does put a score in the news score. Well, anyways, news of 0. And then when we do the news, we write our own examination. So we've seen this patient. In A&E, it's always important to write if the patient's alert or not and their GCS score. Okay, so alert, GCS of 15. Of course, we're just going to do a quick, examination to make sure that there was no head injuries, even if the patient tells you otherwise, because sometimes the patient might have like memory issues that we're not aware of. So let's just say we checked it and Pearl, normal eye movement. Okay, right, no facial dropping. So there's no reason behind this fall or slurred speech. Okay. And then we're coming to the injury itself. So this patient was unable to weight bear. She fell, and let's say leg rotated, unable to straighten.
Just a small question.
And plus plus. Yeah.
When do we decide to do an A to E assessment under examination?
Do you mean like a head to toe examination?
No, airway, breathing, circulation, disability, and then exposure.
Oh, you mean like the A to E? Usually in A&E we do it, but
Okay.
again, it's not something that we do with every single case, because if someone is coming in, for example, let's say this is a fracture. I would say it would be very like unimportant and not necessary to do an AT examination. We usually comment on them sometimes, especially if it's something that's related to the case that we're seeing. But most of the time, we focus on what the patient is coming with. Okay. You might write things that show us that the airway is intact. So if this patient doesn't have slurred speech, talking in full sentences, for example, it means that the airway is intact. Okay, you might write stuff like normal movement, normal eye movement, breathing nil. You can write this stuff if you want to, but most of the time we don't do A to E with every single patient that comes in. Now, if anyone's coming in recess, however, we always do this for every single patient coming to recess, regardless of what they're coming with. Does that make sense?
Yeah, it does. And maybe something small.
Yeah.
What's the average time for clerking each patient? I know the different patients have different situations, but just looking at the whole
So
day, basically.
So with in A&E, there isn't a specific time, because some patients, honestly, they might take 2 hours, especially if they're very like troublesome patients or they have a very complicated history. But usually one patient is roughly 1 hour. Okay. It might be more. So sometimes in a whole 12-hour shift, you might only be clerking 4 patients and no one is going to tell you anything. But if this is your normal pace, if every single shift you're only clerking 4 patients, someone might flag it up. But I would say every single day is different and every single department is different. In A&E, there's no pressure much in seeing tons of patients, especially that we know that the severity of each patient is different. Someone might come in with a cold and it only takes like a 10-15 minute consultation. But with this patient, I would say it would take roughly an hour to sort out. And we'll tell you why now in the management, okay? But someone coming in with falls, it's around an hour. Does that answer your question? I think that it does. Okay. So
Yeah, that's fine. It's answered. Thank you.
yeah, thank you. So after we've done the examination, okay, we basically write our impression or diagnosis. So our initial impression that this patient might have neck of femur fracture. Okay, it's abbreviated as NOF. What is our plan? Our plan is basically, of course, to get X-ray. Usually in patients with query NOF, they've already had an X-ray. Okay, so X-ray, if we found in the X-ray that this patient actually has a neck of femur fracture, then we're gonna do what we call a nerve block. Nerve block, ortho, admit under ortho, and of course pain relief. Okay, it's something that you need to put on because we're doing the nerve block, and the nerve block is going to stay there for a good 12 to 24 hours, but then it's going to wear off. So pain relief is something else that you'll put on. And then you'll admit under ortho, and that's your job basically. So for this patient, we're just going to go back real quick to the presentation.
I have a question.
Yeah, sure, go ahead.
So, are you going to give the analgesics alongside the nerve block? Because it takes 12 to 24 hours, like you say, to wear it off.
Usually no, unless you're not doing the nerve block now. So we'll have a look at this X-ray and then I'll answer your question in more details. So if you all can see the X-ray here, what can you see on this X-ray?
Well, there is a fracture.
Yeah,
Yeah,
where
Left hand
left.
side.
left-hand side. Yeah,
Left.
perfect. So there is a neck of femur fracture at the left-hand side. And usually on examination with these patients, you're going to find their leg rotated. Okay, one leg is shorter than the other, and you're not able to open it at all. You're not able to move it at all. The pain is very severe. So please, when you're examining these patients, don't attempt to move their leg around. As I said, usually these patients would have an X-ray before coming in, and you would already know before seeing the patient that they've had a fracture. But in some cases, when the A&E department is very busy, you might not get an X-ray done before that. So we've seen this patient. This patient has an off. Now we need to do a nerve block. Do you all know what nerve block is? Does anyone not know what a nerve block is? No. Okay. Yeah, some of you don't. Okay, that's fine. Yeah, so nerve block is basically putting local anesthetic into the fracture. And we put it around the nerves, around the fracture area. And it's done either blindly or through ultrasound. Now, most of the time in A&E, we do it via ultrasound. And that's why this needs a senior physician to do it and not a junior doctor. And this comes to your question about an analgesia. Usually we do prescribe pain relief before doing the nerve block because it's going to take some time for us to find a senior who's going to do the nerve block for us. Okay, because they're also seeing patients until they're free and they come and do the nerve block. In A&E, most of the time we do the nerve blocks ourselves. But if ortho has accepted the patient and they're happy to do nerve block themselves, they might do it themselves as well. But in some of the trusts, the protocol is that we do the nerve block. Usually you give a strong pain relief because this is a fracture. The pain is quite bad, so you might give cocodamol, morphine, even. Yeah, you do. You give opioids. Please don't give paracetamol for these patients because you're just torturing them. This is a very severe pain. So start with cocodamol or even morphine if you need to, and just wait for the nerve block to be done. Once the nerve block has been done, this patient gets instant pain relief, and it lasts them quite long. And then they'll be operated on by the ortho. If they operate on the next day or whatever they want to operate on, it will just be their decision. In very, very rare cases, ortho might not operate on these patients if they think, the risk outweighs the benefits, okay? But this is not our job as an A&E doctor. Nerve blocks are done by seniors. Unless you know how to do them, unless you're someone who's a professional in doing nerve blocks, please don't attempt it yourself, okay? It's usually done by seniors. It's something that you can write in your portfolio as a COT or even a CBD, but don't do it yourself. Okay, and if you're someone who's doing A&E and then has an ortho rotation somewhere, I would say it would be a good idea for you to learn the nerve block. Nerve block are not only done for neck or femur fractures, they're sometimes done when you're suturing like fingers or when you're doing certain fractures, but mainly we do it for enough. So this is our first case. Once we've done all this for the first case and we clocked it, this patient needs to be referred to orthopedic. So you're just going to pick up the phone and you're going to ask the ortho team to sort out this patient, okay? So is this clear for everyone?
Yes, thank you very much.
Yes, it is. Could I just see the first page where you took the history from? The Word document.
Yeah, the Word document. Yeah. Do you want to see it again? Is that what you're saying?
Yeah. Yes, please.
Yeah. So here is the first page. This is just a Word document, but on the computer system, it's gonna look more tidy. But this is how you write. It's basically the template that we use to write down the documentations. Is that okay? Is that what you wanted to see?
Yeah, I wanted to see just the top.
The what? Sorry?
The top, just that.
The
Thank
top.
you.
Okay, yeah.
Yeah, thank you very much.
You're welcome. So let's move on to our next patient. The next patient, I'll be expecting you to do it on your own. Okay, so I'll just tell you the case. So this is a 60-year-old male patient attending A&E due to left-sided weakness, which subsided within 2 hours. So please, if someone is going to volunteer to clerk this patient for us, or even a few of you who want to clerk this patient, tell me what you need to write and I'll write it for you. So any volunteers at all that want to give this a go?
So this is a case of TIA.
Yeah, so this is a query TIA. Um, what are you going to write? So you're someone who's clerking. What are you going to start writing?
Okay, as at first I will assign the patient under my name.
Okay, perfect. Yep.
And then I'll start with the presenting complaint.
Yeah, so you're going to just write Edie Clerking, doctor. Sorry, I didn't get your full. Is it Tasha or
Yeah, I can write it down, no worries.
Tisha, right? Yeah.
Doesn't matter. Yeah.
Yes, to one. And then you're going to write the presenting complaint. What are you going to write in the presenting complaint?
Left-sided weakness for
Yeah,
2 hours.
left-sided weakness. Okay, perfect. And then we have the history of presenting complaints. So I'm your patient. Just ask away. What are you going to ask me?
I will ask you about um, the duration definitely, and how did it start,
Hmm,
and any weakness in any part of your body remaining. Um,
okay. Yeah, that's fine. So I'll tell you, doctor, basically, this morning I was just having breakfast as normal, and then suddenly I couldn't hold my spoon. It was very scary.
okay. So did you feel any weakness in any of your legs, maybe?
No, it was just my arm.
Okay, just your arms. No
Mm.
facial weakness at all.
I think my face was okay.
Okay. And are you having any weakness right now?
No, so it actually got better on its own. I think like within an hour or two.
Mm-hmm. And did you dodge off during this time?
Did I what? Sorry.
Dodge off during this time? Any sort of loss of consciousness or anything else?
No.
Oh, well, any chest pain,
No, not really.
any dizziness?
No, but I was panicky, so maybe I made myself a bit dizzy.
All right. And is this the first time you're having this kind of condition?
Yeah, it's never happened to me before, and that's why I was really scared. I thought I was having a stroke.
Mm-hmm. Okay. Um, okay, I think that's all for my sorry, yeah, history of presenting complaint.
Okay, anyone wants to ask any more questions in the history of presenting complaint?
Yeah, I think it would be good to rule out any cardiac history or any cardiac related symptoms
Yeah,
like
I did ask about chest pain.
yeah, she did ask about chest
um,
pain. Is there anything else that you want to ask about?
Any loss of vision?
Slurred speech.
Yeah,
Lots.
slurred speech, loss of vision. So when you're taking a history about anyone who's having any weakness, just cover yourself with everything because some patients would tell you no, and then you find out that it's a yes. So any slurred speech, any facial dropping, any weakness anywhere, loss of consciousness, dizziness. And it's very important with these patients to ask if it happened again. So I've had this weakness, it lasted 2 hours. Did it happen again and then it settled again? So it might have happened again and then lasted 10, 30 minutes and then it went again. What kind of TIA is this? Does anyone know what kind of TIA is this? It's happened,
Re
got better,
re Recurrent?
uh, close enough. It has a very specific name. Has anyone heard about crescendo TIAs?
Crescendo.
Yeah, crescendo TIAs.
Yeah, I've heard about it, but totally forgot it.
Yeah. So crescendo TIA refers basically for a pattern where a TIA happens repeatedly. Sometimes we call them crescendo decrescendo TIAs, and they're important because we deal with them differently than the normal TIA. So if a TIA has happened repeatedly or recurrently in 24-hour, then sometimes we don't treat it as a normal TIA. Okay? So it is a red flag, and we usually treat it as a clot. Okay? And basically it tells us that there's an unstable clot that deep keeps on, causing a clot like a mini stroke and then unclotting and causing a mini stroke. And this might end up being a large stroke. So just ask, does this happen again within the span of the 24 hours? So this patient told us it started this morning while having breakfast, where we have left-sided weakness and no other neurological abnormalities. And just please specify. So no, for example, facial dropping, uh,
No
let's
slurring of speech.
yeah, speech, vision disturbance. So just write in details. In any neurological history, please take as much details as possible. Subsided in 2 hours and didn't happen again. Okay. So basically, this is a rough history of this patient. This patient panicked. He came to A&E, and then patient, let's say, brought in by wife, for example. Okay. And sometimes you can find these patients, this happens in the morning and then they come in nighttime. So you might just ask them why they decided to show up at nighttime. And it could be that because it happened again. It could be because their wife is nagging them. Whatever reason it is, as long as it's not medical, it's none of our business, okay? So again, we'll take a past medical history. Let's say this patient has hypertension. And what else do we do after past medical history?
Medication history.
Yeah, medications. And then we write this patient, let's say, is on Ramipril. And then with these patients, especially the ones that are query stroke TIA, it's important to ask them if they're actually taking their medication. It could be someone who's having a TIA or a stroke, he's having hypertension or AFib, and he just doesn't care. He's not taking his medications. So at least we'll know why this has happened or where did the risk come from. Okay, so is the patient compliant? Yes, the patient is compliant. You can write this in the history of presenting complaint. Patient, known hypertension, taking medications. Very good. Okay. So what else comes after medication? So he takes his medications, he takes
Allergies.
a single day. Sorry, I couldn't hear you.
Any drug allergies?
Yeah, any drug allergies is important in medications. So there's no known drug allergy. No known drug allergy is abbreviated in NKDA. Okay. What else do we ask?
Social history.
Yeah, social, and what is important specifically in this case for social history? Yeah, someone's saying family history. Again, you can ask, especially in cases with strokes, TIA, if it's a young patient, please ask about family history. So,
I think alcohol and smoking are particularly important in this case.
yeah, exactly. So this is a known smoker. He smokes 10 cigarettes a day. He's been smoking since the age of, let's say, 14. Okay. Social drinking. And job is important. Does this patient have a stressful job? So let's say he's a truck driver. Okay, does anyone know why jobs are important in TIAs and stroke?
Definitely, it is related to DVLA.
Yeah, for DVLA.
Patient, yeah, if he is a truck driver, then he must inform the DVLA and he is driving.
Yes, perfect. So anyone who's had a TIA, stroke, MIs, anything that's DVLA related, please ask the patient. Usually it's not an A&E doctor's job, it's the GP or whoever is going to admit the patient to follow this up, but it needs to be in the notes that you've told the patient not to drive. Because in TIA, most of the time you're going to send them home, okay? So this is truck driver, and dependent, let's say independent with ADLA. Okay, so we've taken our history, you've taken everything. Now we need the investigations. What investigations are we going to do for this patient?
CT
ECG.
brain, ECG,
Okay, we have ECG, and ECG is normal sinus rhythm. What else are we doing for this patient?
bloods,
Bloods,
Carotid Doppler.
carotid Doppler. Okay, so bloods. Look cute. So you all mentioned CT head. Some of you have mentioned carotid Dopplers, which are a good idea, but we don't do them for TIA patients. Okay, so according to guidelines,
Yeah,
if
just sending them to the TIA clinic
yeah,
within 24 hours.
first thing to know is that CT heads are usually a senior investigation, so we can't really, as a junior doctor, you can't really ask for them. You can it's most in the most trusts it's going to be a senior discussion, and you're going to ask one of the seniors to book it for you. Okay, in some trusts they do allow the juniors to do their own booking, but it's rare. See, again, CT head and carotid Doppler is a TIA clinic decision. We don't do them in A&E. If it's a stroke, this is a completely different scenario. But this is a TIA, we don't do it. We just do ECG, we do bloods, we do the full neurological examination, make sure there's no neurology, and then we basically just, examine the patient. This has to be a head-to-toe examination. Any neurology coming is a full head-to-toe examination. Let's say there's nothing, the examination is normal. Just please document it quite well. So what do you look for in this patient? What are you going to examine?
definitely a GCS, along with cranial nerve examinations, like 7th cranial nerve is very important.
Yeah, exactly. Yeah, what else?
Look for any that means
Jerks,
I look out for any drooping or
Yeah,
facial deviation, any focal signs, and weakness, leg
yeah.
weakness.
So you're examining the limbs. Yeah. Um,
jerk,
Sonia said power in upper limbs and lower limbs. That's right. Pupil examination, gait. So if the patient
tone,
is able to walk, just ask them to walk around the room. What else? What else do you examine? Necks, okay.
jerks,
Yeah, jerks. We don't always do them, but if you want to do them, that would be something else. That would be a good idea. Cerebellar signs. Please don't forget your cerebellar examination because these might be hidden signs that suddenly you find the patient with a bleed or with a clot somewhere. So just do the cerebellar movements with them. Any signs of confusion? Yeah, so you're doing a full head to toe examination. Always ask about sensation when you're examining them. So can you feel me okay? Can you feel this side just as that side? And that should cover all your head to toe examination. Now, our impression here is this is a TIA. Okay. Plan, which if is what do we do for TIAs? So this is a patient that has a TIA. What do we give?
This
What is the management?
this patient presented to us within 2 hours of his symptoms. So
Mm-hmm.
I think we need to refer him to the TIA clinic within a week.
Okay.
Within 24 hours, I
Oh,
think.
sorry, within 24 hours. Yeah, 24 hours. Yeah.
So
We're gonna give aspirin. Yeah.
we're gonna give aspirin. What is the dose that we're giving? Aspirin 300. Yeah, that's right. So
Loading dose.
yeah, so 300 milligram TIA clinic, and this is a patient coming within 24 hours, so he needs to be seen within 24 hours. Does anyone know the specific guidelines? Who is seen within 24 hours? Who's coming in?
If a patient presents within a week of presentation, the clinical symptoms, obviously, then he should be referred within 24 hours.
Yeah,
But if
perfect.
it's more than a week, then we can refer him within a week to
Yeah,
the TI clinic.
that's right. Yeah, perfect. So we're going to do our aspirin. We're going to do our TIA clinic referral. Make sure it's an urgent referral. And then we're just going to ask this patient to go home. Anything you want to say or give to this patient before sending them home?
Safety
Lifestyle
net.
advices. Yep.
Yeah, sorry, I think it Julius that was talking.
Yeah, you could do some safety netting and
Yeah,
provide them with a leaflet. Yeah, because there is a possibility if it's a crescendo, it may happen again, or it could uh, become a fully fledged stroke,
sure. Yeah, that's
depending on the causative reason. Yeah.
yeah, perfect. So please safety net this patient. As Kemi was saying, fast. So tell them to look out for certain signs. Don't drive. Tell them that they're going to have their clinic within 24 hours because if they don't, then they need to come back to the hospital to ask where their referral has gone. Leaflets, there is leaflets for TIA, so give them the leaflet because then it will let us know exactly what to look out for. So you usually tell the safety netting for patients, but they tend to forget. If there's a leaflet, please give it to the patient. Okay? Yeah, and sometimes see GP to discuss smoking and alcohol. Yeah, if that's something that you want to discuss. This patient is a social drinker, so we're not really going to focus on his alcohol, but smoking cessation definitely. So you can send in the ED summary saying queer TIA. This patient has some risk factors, which is hypertension. Make sure the hypertension medications are optimal and smoking cessation advice. If you're giving smoking cessation advice yourself, just write them in the notes, okay? And this patient is just going to be discharged. Is everyone okay, or are you tired? Do you want to do one last case, or should we end?
Yeah, we can do one more.
Yep. Is everyone happy for us to do one more case?
Yeah, sure.
Okay. So we're going to do our final case, which is again a very common case in A&E, and we see it all the time. And this is a 25-year-old female presenting with central crushing chest pain. Okay. Usually we do an ECG before with anyone who's coming into A&E. So this has to be in the triage. In very rare cases that you don't get an ECG, but this is the ECG of the patient. Anyone can tell me what the ECG is showing.
It's sinus tachycardia.
Okay, sinus tachy. Anyone else wants to have a look and see what this ECG is showing, or is everyone happy with sinus tachy? No volunteers? I know you're all tired, but we're almost done here. So actually this is a normal sinus rhythm. Okay.
Yeah.
Yeah, it looks normal. Exactly. It's a normal sinus rhythm. Um, it's very common for you to get young patients coming with chest pains into A&E. What is the main thing that we need to make sure this patient doesn't have? What is our most, concern with these patients? Apart from that, it's nothing, and because they're young. What is something that you don't want to miss? Make
MI.
so okay, so this is a please, I'll give you another chance, okay? So this is a 25-year-old. MIs are not very common in 25-year-old, but there's something that you shouldn't be missing. It's life-threatening.
Okay,
Aortic-
ectopic
Pulmonary embolism.
dissection.
Okay, so everyone,
cardiomyopathy.
okay, cardiomyopathy, something else that's
Aortic dissection.
yeah, aortic dissection. You don't want
Aortic
to miss
dissection.
an aortic dissection in a young patient because it's deadly, okay? So this is the only thing that would make us see this patient in A&E, because usually chest pain, normal sinus rhythm, we send them to urgent care. So some patients you might find them coming to A&E and then referred back to urgent care. A lot of these patients that are coming with normal sinus rhythm are going to go back to urgent care. Now, this patient, just because of the history, she's saying she has a central crushing chest pain. We might be seeing her in A&E. And the most important thing that we don't want to miss is aortic dissection. Now, PE is another possibility. Of course, PE does happen in young people. It's rare, but we see it a lot. We see it more than you would expect, actually. So, what investigations do you have in mind for this patient?
To start with, a chest X-ray,
Yeah, chest X-ray might be one of them.
ABG.
blood.
D-dimer.
The TROPS, yeah, D-dimer. The ECG would give us a bit of an idea of the PE. What do we see in an ECG in a PE?
S1T3Q3.
Yeah, what else is more common than that? Something very common.
Tachycardia.
Yeah, exactly.
Yeah.
A lot of patients with PE are going to be tachy. They're going to have sinus tachy. So this is something that would show us they might be that their new score is high, so they're not very stable. They're desaturating. They're tachycardic. It might only be tachycardia. So take care with these patients. Make sure that we're not missing out PE or a aortic dissection. Now, let's clark this patient real quick together. So ED clarking.
I've been lucky enough to see an S1Q3T3 in PE.
Really? Okay.
Yeah, yeah.
They're rare actually, but yeah, you can see them. Most of the time we do see tachycardia, but they are rare.
We
And
saw it retrospectively when we went back to look at the ECG.
okay, well, that's interesting actually. I think I've only seen once in my life. Um, yeah, and everyone is calling everyone to come and see it because we don't really see it much. So this patient is coming with chest pain. So let's do history presenting complaint. I want someone who's not participated much. So I want like a new fresh volunteer to take a history, please. You're gonna do it sooner or later in like 2 weeks, so I think it's better to do it now because no judgment here. So if anyone just wants to take a history, we've not heard their voices much. Anyone wants to give it a go?
When did it start?
Yeah, okay. Yeah, go ahead. Desire, you said when did it start, isn't it?
Yes, I did. Okay, okay. Does it radiate anywhere?
Okay, radiation. Yeah, perfect. So let's say it started 3 days ago. No radiation. What else do you want to know?
Has it had it before?
Okay, on and off.
Has there
Or
been any trauma to the chest?
no trauma.
Any difficulty breathing?
No shortness of breath.
Any fever?
No fever.
Any
What?
cough?
So any what? Sorry.
Any cough or recent viral symptoms?
No, no cough.
Mm, is okay, that's pretty sure presenting.
Yeah,
Okay, the other ones I have to ask this in the other segments.
sorry.
The other questions I have is for past medical history.
Past
I
medical history.
haven't.
Okay. Anyone else wants to ask anything in the current exacerbating or relieving factors? Yeah, exactly. So let's say it gets worse when I'm laughing.
Okay.
Okay, better when I write.
Socrates for the pain. Just
The character of the pain.
Yeah, the character of the feign is central crushing. Okay, that's how she describes it. First time, yeah, for, it's ongoing for like a month or so, but for now, for 3 days, it's been consistent.
Has it ever happened before?
Yeah, it's happened over the last 3 days, but not before in like years.
Okay.
Is it a particular time that it happens?
No, random, random. Can happen at rest. Can happen sometimes when resting. Uh, and if you ask specifically, like when moving my arm. Okay.
Okay. Have you given any thought as to what it could be?
I don't know, doctor. I'm very scared that it could be a heart attack because I have a family history of heart problems.
Okay. Is there anything specific you'd like us to do for you today?
I just really want to make sure this is not a heart attack. Anything that you're gonna do for me, would really help.
Okay. Say our best to help you with that then.
Thank you so much, doctor. Is there anything else that you want to know? Do you think this is a heart attack? Am I dying? These are all questions that the patient's gonna ask you. Am I dying?
It's normal to be scared, but we'll be able to do some tests and then find out and treat you. Would you be okay with that?
Yeah. Thank you so much.
All right then.
Okay. So we've taken a history. Anyone wants to ask anything else in the history, or everyone is happy? That's good
Any
enough.
pain at the back of the legs?
No leg pain. And when you're mentioning about the leg, no leg swelling, okay?
Okay.
What else do we need to ask in the presenting complaint?
Recent travel?
Yeah, recent travel. Perfect. So no recent travel. How long did it last? So it usually lasts about like minutes. Okay, minutes. Any reflux, burning chest associated with meals. So it's not associated with meals. Not really, no reflux, or abdominal pain. And that's a good question because sometimes abdominal issues are gonna come on as a chest pain. Okay. So we've taken a very thorough history. Is this patient now past medical history? Usually a 25-year-old is not going to have much, but might have a few things. So our patient here is fit and well, no medications, none. And then socially, smoker, no alcohol. Okay, family history, MI. Okay, and that's what she's worried about. But when you ask, they're all over 60. Okay, and it's important to ask about the age of MI, okay? Please ask about the age of MI when they tell you. Sometimes patients come in, they're like, oh, all my family died of MI. How old was your family when they died of MI? Was it an 80-year-old or was it like an 18-year-old? Because it really differs, okay? So we've done that. We've done the new score, which is 0. Our patient has a normal sinus rhythm, bloods, and usually what we do is we say including TROPs. Okay, that's something that we like to write, including TROPs are nil. Okay, so for anyone who reads knows that we actually did a TROP. This patient is alert, talking in full sentences, just clear, good air entry, all sounds regular, and she's tender over the chest wall. Okay, what does this patient have? Yeah, use of recreational drug is important in young people.
Could it be costochondritis?
Yeah, costochondritis.
Musculoskeletal chest pain.
Yeah, so you can say MSK, or if you want to be very specific, this is chondritis. Okay. What is the plan? It's basically discharge. Discharge, leave.
Just a small one.
Yeah.
I had a couple of questions, but this may skip my mind.
Yeah, sure.
Is it a must that you should have an impression or not?
Yes. You have to have at least a differential diagnosis. You can't write like 100 differential diagnoses. So let's say we're worried about aortic dissection, we're worried about PE, but the most likely diagnosis is costochondritis. Please do not write PE, MI, aortic dissection, MSK, costochondritis, all in this tiny bit. So usually we're expected to only write one thing or maximum two things max. So we're querying costochondritis, but we're also, let's say we're scared about aortic dissection, or let's say we're gonna write rule out aortic dissection because you're just scared about how the pain is presenting. Although the vitals are normal, you can get a chest x-ray before sending patient home. So you say it's chest x-ray, if normal, home, and discharge with pain relief. Okay. If abnormal, of course, everyone's gonna call you. You're gonna know it's abnormal because they're not just gonna wait for you to review it yourself. Okay, was that okay for everyone? So this patient just goes home with pain relief, and you normally ask these patients to follow up with their GP. So this is someone that you're going to send the GP to follow up to make sure it's got better and it's not anything to be concerned about. Any questions at all?
Yeah, just two questions for me.
Mhm.
One is, as you're saying this patient, you're also asking for investigations.
Yeah.
In between there, before you get the results, let me say this patient, you're querying aortic dissection and you could start them on some paracetamol.
Mhm.
Do you leave them there, then go start handling another patient? Because some of these tests may not be instant.
Yeah, so in A&E, the way we clerk is that we see this patient. Let's say we booked someone for something that might take some time, especially MRI, CTs. We leave the patient since we have a plan and we've covered for the management, and we go and we clerk another patient. But just don't clerk so many patients at the same time. So if you have two, three patients that you don't know what you're doing with them, they're still in the department with no discharge or admission, I would say do not take another patient. The maximum is like three patients. Sometimes we only do two patients, and then we deal with them, we discharge them or admit them, and then we take on new patients. Because if you take so many patients at one go, you're gonna be lost. You're just gonna be going everywhere. You're not gonna know what to do. So I would say 2 to 3 max clerking at one go.